Good afternoon, everyone. Welcome to today's webinar talk on clinical radiological correlation on the behalf of VDC webinar series. Today's chief guest for our talk is Dr. M. Rajendra Reddy, sir, who is a consultant urologist at Aster Prime Hospital, Hyderabad. I welcome you, sir. Uh, I would like to give a brief introduction about Rajendra Reddy, sir. Sir has done his MBBS from Osmania College, Hyderabad, and later MS General Surgery from Kasturba Medical Hospital, Manipal. Sir has worked for 14 years in UK in urology, in which includes 2 years as consultant urologist at Glasgow, UK. Sir has completed FRCR in urology from Royal College of Surgeons, Edinburgh. Sir has also a fellowship in European Board of Urology. Sir has numerous publications of 25 publications in international and national journals, and he has also given multiple national and international talks in conferences. Sir also has vast teaching experience in UK as a clinical lecturer, undergrad examiner, and also an examiner for FRCR urology. Sir's interests are mainly in laparoscopic surgeries, robotic surgeries, renal transplant, and stone surgeries. I thank sir for being part of this webinar series. Thank you, sir. Today's speaker for our webinar is Dr. Arun Santosh, who's a consultant radiologist at Vijaya Diagnostic. Uh, Dr. Arun Santosh has completed his MBBS and DNB from NIMS Hyderabad. Dr. Arun has experience in radiology of 8 years, which includes 5 years in Vijaya Diagnostics. I welcome Dr. Arun Santosh.
Yeah, thank you very much, Dr. Vikram. Good afternoon, sir. I think I'm audible to you.
Yes,
Am I audible?
yes, you are audible, sir.
So I shall start the presentation, sir. Shall I start?
Yes,
Good afternoon, one and all. I thank Vijaya Diagnostic for giving me this opportunity. Today I'm going to present a short seminar on imaging of adrenal masses. So firstly, the adrenal gland. The adrenal gland is named for its location adjacent to the kidneys, that is adrenal, also known as suprarenal glands. And they are either a Y-shape, V-shape or T-shape, pair of important endocrine glands situated on the posterior abdominal wall over the upper pole of the kidneys behind the peritoneum, and they are enclosed in the perirenal fascia. Each adrenal gland has got one body and two limbs, that is medial and lateral limbs. Medial and lateral limbs. So histologically, the adrenal gland consists of adrenal cortex and adrenal medulla. So the adrenal cortex includes zona glomerulosa, fasciculata, and reticulata, which we don't want to go in detail. And adrenal medulla, which includes the 10% of the adrenal gland, and it is made up of chromaffin cells, which secrete the epinephrine and norepinephrine. So the coming to vascular supply, here we can see these both are the right adrenal and the left adrenal glands situated above the top of the kidneys. And the arterial supply is by the inferior phrenic artery superiorly, aorta medially, a direct branch can be seen, and renal artery can be seen supplying inferiorly the adrenal gland. And the venous drainage on right side, it drains into the IVC, and on left side, the left adrenal vein drains into the left adrenal vein and then into the IVC. So the lymphatic drainage from the adrenal glands is by the para-aortic or paracaval lymph nodes. So this is the normal CT appearance of right adrenal gland. This is the part of body, and this is the lateral limb, and this is the left medial limb. This adrenal gland is situated posterior to this is the IVC, and medial to this is the margin of the liver, and this is lateral to this right crux of diaphragm. Similarly, this is the representation of both adrenal glands. Here we can see this is the Y-shaped right adrenal gland and Y or V-shaped left adrenal gland. Here we can see, and the left adrenal gland is seen here just above the upper pole of the left kidney, posterior to the distal body and tail of pancreas, and and lateral to this left crux of diaphragm. So normal measurements are generally around 4 to 6 centimeters in length, width is 2 to 3 centimeters, and each limb normally measures 5 mm in width, and the body measures less than 8 to 10 mm in width. So the criteria for enlargement is, should I continue? So the length is more than 6 centimeters, AP diameter more than 3 centimeters, and limb thickness more than 6 mm. So generally, we visually when we compare whether the adrenal gland is thickened or not, we compare it with adjacent the crux of diaphragm thickness. If the adrenal gland appears more in size than as compared to the adjacent crux of diaphragm, we generally take it as the gland is either enlarged or thickened or can be due to hyperplasia. So the imaging modalities what we use for imaging an adrenal mass are ultrasound, CT, and MR. So and part of nuclear medicine, which we are not going to deal in detail. Ultrasound, it is primarily reserved in pediatric population because of lack of ionizing radiation and can be seen better due to less body fat. However, in adults, due to excessive body fat, we may not be able to normally see the adrenal glands at most of the time. Hello. In adults, normally it is difficult to visualize because of the excessive body fat. However, whenever a lesion or mass is seen, we can generally catch hold of adrenal mass.
అవును ఓకే నేను చేస్తాను
Next, coming to CT protocol. The routine CT protocol for adrenal imaging is we first take a non-contrast abdomen, then CECT abdomen, that is 70 seconds delay, and delayed scan, that is after 15 minutes. The CT imaging is the imaging modality of choice for evaluating adrenal glands because of its morphology and ease and 3D dimensions and the masses associated with it. So high resolution CT of upper abdomen we take using 1 to 3 mm thick slices, reducing the volume averaging, and is most accurate technique for identifying adrenal lesions. Contrast enhanced CT and delayed images help in further characterization of the lesions. Generally, we use 100 to 150 ml of contrast at a rate of 3 ml per second, and images of post-contrast are required at 50 seconds and 15 minutes delay after the contrast injection. So MR of the adrenal glands is modality of choice for further characterization of adrenal lesions which were indeterminate on CT. Generally, first initial modality we go for CT rather than MR. And MR parameters generally include T1 and T2 weighted standard imaging sequence. Along with, we use a chemical shift imaging. The T1 weighted imaging signal shows normal adrenal as low signal intensity against the high signal fat, and most tumors show high signal on T2 weighted image and low signal on T1 weighted images. Contrast enhanced dynamic MRI used in differential diagnosis of adenoma, metastasis, granulomas, and pheochromocytomas. The chemical shift imaging is primarily used to detect whether the lesion is an adenoma or a non-adenomatous lesion. So this is a normal gland, normal MRI of a left adrenal gland. Here we can see this is the Y-shaped adrenal gland, the body, the medial limb, and lateral limb. Similar, this is the axial image, and this is the coronal image. Here we can see very well. This is an incidentally detected left renal cyst is also seen here on the T2. This is the T2 image, and this is the T1 weighted image. And on nuclear medicine, we generally use FDG PET, iodine 131 MIBG, and in iodine octorotate scans. These are generally basically used for the tumors which are like chromaffin cell originating tumors, that is pheochromocytomas. So adrenal masses generally can be grouped as neoplasms and other masses. And in neoplasm, the cortical ones are the adenomas and carcinomas, and the medullary ones are the pheochromocytomas, neuroblastomas, gangliomas. These are the pediatric tumors, and lipomas, myelolipomas, and metastasis. And granulomatous lesions include tuberculosis, histoplasmosis, and cystic lesions that include benign endothelial cysts or pseudocysts and parasitic cysts. So adrenal masses can be grouped as adrenal masses which are with normal function or hyperfunction or insufficiency. So normal function, these are the most commonly adrenal tumors, that is the incidentalomas we call them as, and they are mostly incidentally detected. These include non-functioning adrenal adenomas or carcinomas, metastasis, lymphoma, myelolipoma, and adrenal cysts. So incidentally discovered adrenal masses. So common incident discoveries can happen on CT, routine CT imaging, MR imaging, and FDG PET. Adrenal incidentaloma are the lesions which are less than 4 cm or smaller and can be unilateral or bilateral. Whenever adrenal incidentaloma is seen, we have to characterize whether it is a functioning tumor or a non-functioning, which can be done by assessing the blood parameters. And on imaging, we have to characterize whether it is benign or malignant. How to characterize an adrenal mass, whether it is benign or malignant? The common site for both benign adenomas and so adrenal is a common site for both benign adenomas and metastatic disease. Even though it is a common site for metastasis, 70% of the adrenal masses in cancer patients are also benign tumors. So differentiation is essential in determining treatment and prognosis. Benign, when it is, then no further treatment is required. In metastatic lesions, it indicates an advanced disease and hence not amenable for surgical resection. Sorry. The characterization depends upon the lesion morphology, perfusion difference, intracellular lipid concentration of the mass, and metabolic activity of the mass. Indicators suggesting possibility of a malignancy. When the masses are more than 4 cm size, they tend to be metastasis or primary adrenocortical carcinomas. Generally, they are irregular in shape, show heterogeneous enhancement, and they show tendency to grow over a period of time. So CT in differentiating benign and versus malignant, two main criteria are used. That is, intracellular lipid content represent an anatomic difference, and vascular enhancement pattern represent the physiologic difference. So non-enhanced CT, when first it is done, many adrenal adenomas can be characterized at non-enhanced CT due to their abundance in the intracytoplasmic fat that tends to lower the attenuation value of these lesions on non-contrast scans, and typically these adrenal adenomas appear less than 10 HU on a non-contrast scan. So various studies show that if it is less than 18 HU, we can consider a possibility of adenoma. Less than 10 HU, the possibility of adenoma is more than 96% specific and 17% sensitive. And at 0 degrees, that is 0 HU value, it is 100% specific and 47% sensitive. At 10 HU, the specificity approaches 100% if size, shape, and change of the lesion is considered. So at 10 HU on a plain scan, we mostly write it as an adrenal adenoma straightforward, and no further investigation is generally required. So this is here actual images. Here this is the post contrast image and the pre contrast image in a patient with lung cancer. Here we can see there is an mildly enhancing right adrenal lesion which had 22 HU. However, the pre contrast image showed minus 19 HU, which is falling lesser than the values of less than 18 HU. So this suggests that the lesion on the plane itself is more favoring towards an adenoma. Since the value is less than 19 HU, indicating a presence of lipid-rich adenoma, no further workup was needed, even though it was a patient of malignancy. So more than 10 HU, does it mean malignant? No, not necessarily. So up to 30% of adenomas do not contain sufficient lipid to have a low attenuation value. These are called as lipid-poor adenomas. So adrenal masses with more than 10 HU require further workup, and this can be done by using two modalities. That is, on CT we use a washout method, that is, and on MR we use a chemical shift imaging. So this is the post contrast image. Here we can see there is a left adrenal mass where the HU value was minus 10 HU. So even a post contrast image, this will directly we could label it as an benign adenoma because of its lesser HU value. This is a non contrast CT. Here we can see there is a left adrenal mass which had a HU value of almost 40. So this is not falling in the criteria of what we thought of an adenoma, and hence further contrast was advised to assess the contrast washout to label it as adenoma before going for further investigations. So contrast enhanced CT, what actually is done? So in dynamic contrast enhanced CT is usually performed in portal venous phase at 70 seconds and delayed at 10 to 15 minutes after the contrast administration. So adenomas, whether they are lipid rich or lipid poor, they show rapid enhancement and subsequent rapid washout of contrast. So whereas metastasis also enhance vigorously, but the washout is bit prolonged. During the portal venous phase, both adenomas metastasis enhance and the attenuation values overlap. Hence, the delayed images of the washout is only important. So here we use two parameters, that is called percentage of washout. So the material is a useful parameter, and the attenuation of the adrenal gland at delayed CT is compared with its attenuation on the dynamic CT in the post contrast. So two specific measurements of washout are used in indeterminate lesions, that is relative percent of washout and absolute percent of washout. So the absolute washout is calculated by using the enhanced CT HU value minus delayed CT HU divided by enhanced CT HU value minus unenhanced CT into 100. And relative washout is used depending upon enhanced CT value minus delayed CT HU value by enhanced CT into 100. So we have to remember, when absolute washout is more than 60% and relative washout is more than 40%, we can confidently say that this is adenoma. And when the lesions do not follow this pattern and the relative or absolute washouts are less than 60%, 40% respectively, then in a delayed scan, most probably they are aggressive lesion and a possibility of a malignancy or a metastasis to be considered. Only if it is more than 60 or 40%, we can 100% label it as an adenoma. So in MR, how to differentiate a benign versus malignant? So by using T1, T2, an enhancement pattern, and chemical shift characterization. So anyhow, as we know, there is significant overlap on T1 and T2 images between adenomas and other lesions. Generally, metastasis and carcinomas contain large amount of fluid, hence they are bright on T2. Adenomas, if they are macrolipid containing tumors, then it can be bright on T1. And the washout patterns are also similar like that of CT. But what is important here in MR, we use something called as chemical shift imaging. In the chemical shift imaging relies on the different resonance frequency rates of protons in fat and water molecules. Here you have two concepts, that is in phase and out phase, out or opposed phase. In phase, the signal of water and fat protons are added, and in out phase image, the signal of water and lipid protons are cancelling out each other. Thus, the tissues which contain lipid and water have a signal loss that they appear darker than the adjacent structures on out phase images, and the amount of signal loss depends upon the amount of lipid within that lesion. So thus on out phase images, adenomas appear darker because of lipid containing thing than on in phase images. Metastasis carcinoma, because they don't have lipid, they appear bright on both in and out phase images. So it should be noted that even MRI cannot be used sometimes if it is very lipid poor adenomas. So these are the here we can see this is the chemical shift imaging. Here this is the in phase image, where we can see the lesion is almost iso-intense to adjacent liver and renal cortex, whereas in opposed phase images the lesion is appearing very blackish or hypo as compared to the adjacent liver and adjacent renal cortex. However, this is because of the what is actually called as the loss of signal on out phase images due to the cancellation of lipid and water signals. So this confidently tells that this is a lipid containing lesion and suggestive of an adenoma. So the loss of signal can be assessed virtually. Generally, in most of the cases in routine practice, we use it as virtually by eye examination only, by comparing with the adjacent liver or spleen. Unless the liver is fatty, we compare it with the standardly with spleen. This is a visual assumption only, depending upon by how much the lesion is appearing darker on the opposed phase image. However, there is one parameters also are there. The loss of signal can be assessed virtually using spleen as an internal control, and liver should not be used because of the underlying fatty infiltration can be seen sometimes, and which can mislead the even the liver can show a decrease in the signal intensity in opposed phase images. So there is something called as adrenal to spleen ratio and signal intensity index. These are rare, but theoretically can be used. So the lesion signal intensity in opposed phase by spleen signal intensity in opposed phase, by lesion signal intensity in phase by spleen signal intensity in phase, or lesion signal intensity in phase minus opposed phase by in phase into 100. So when the adrenal to spleen ratio is less than 0.71, it is suggestive of adenoma, or the lesion signal intensity index of the adrenal lesion is more than 16.5, it is suggestive of adenoma. So here we can see this is an axial post-contrast arterial phase image done for some other case. Here we found they found a left adrenal lesion where on post-contrast the HU value is 18 HU, so slightly indeterminate nature it was. So the patient was subjected for in phase and out phase chemical shift imaging MR. Here the ROI curves were drawn on the left adrenal mass and the spleen. Here the signal intensity values are there, and upon using the previously described these formulas, it turned out that the adrenal to spleen ratio is 0.66, which is less than 0.71, and the signal intensity is 39.5, which is more than 16.5%, indicating that it is an adenoma. So whenever we see an adrenal mass, so first we go with a plain CT. If it is less than 10 HU value, then if it is non-functional, just an yearly evaluation, or we can leave it like that. If it is functional, you have to remove it. If the HU value is more than 10, we have to characterize it less than 6 centimeters. If it is functional, anyhow surgically remove. If it is less than 6 meters non-functional, perform a delayed contrast scan and calculate the percentage of washout at 15 minutes. If it is more than 60% washout, then it is suggestive of an adenoma. And if there is no change in size of 12 months, again follow. If it is increasing in size, then again surgical remove. If the lesion HU value non-contrast is more than 10 and more than 6 centimeters, you have to go for a surgical excision. So coming to the adrenal adenoma, which is the most common incidental finding, and generally it is benign with no malignant potential, and mostly adrenal adenomas are non-functional. If they are non-functional, no further intervention is required. This is an stat image of ultrasound. Here we can see this is the spleen, and here this is the shadow of the left kidney. Here we can see there is a heterogeneously hypoechoic lesion in the left suprarenal region. And in benign adenomas, we can see this is the axial CT image. Here we can see this is the normal right adrenal gland, the body, the lateral limb, and the medial limb. And here we can see there is an oval iso to hypodense lesion in the left adrenal gland. And when we see the HU, generally these lesions are round, generally, as I said, round to oval, homogeneous, mostly homogeneous. If they're less than 4 centimeters and unilateral, low HU values on plain CT, this is less than 10, as I already told, and rapid contrast washout and absolute contrast washout of more than 60%, And on chemical shift imaging, as we already spoke about it, that is they show loss of signal in the outphase image and appear darker than adjacent structures. So here we can see these are the sequential images in non-contrast, post-contrast 60 seconds, and delayed 15 minutes images. Here we can see there is an oval-shaped iso2 hypodense lesion in the right adrenal gland, and ROA curves were drawn. And here we can see the HU value is 24 on plane scan. So it was indeterminate and not falling less than 10 HU. However, on the post-contrast 60 seconds, the HU value is 88, and on the delayed 49 HU. When using the formulas of absolute and relative washout, the percentage calculated was 62 and 44%, which suggestive of adrenal adenoma, even though the HU value of the plain lesion was around 24 HU, and what statistically we take as more than 10 HU. Because of the percentage washouts were falling into the criteria of more than 60%, more than 40%, still it was labeled as an adrenal adenoma and left with only follow-up. This is again an MR imaging. Here we can see this is an in-phase image where the lesion is appearing iso2 hypointense to the liver, almost isointense to the liver, but on opposed phase image you can see that there is significant signal drop and the lesion appearing darker or blacker as compared to the adjacent liver. This suggests that the tumor is containing a high amount of lipid. So this is a favors of adrenal adenoma. Then coming to adrenocortical carcinoma. This is an irregular lesion and inhomogeneous generally. More than 4 centimeters, can calcify. Higher CT HU values on plain scan. Delayed washout, same like that can be like adrenal adenomas. Absolute washout is less than 60%. They are hypointense on T1 and high signal on T2. They show increased FDG uptake and local invasion or metastasis can be there. Here we can see there is a large heterogeneously hypodense lesion showing heterogeneous enhancement in the left suprarenal region. As we can see, the left kidney is pushed downwards. The lesion is showing significant areas of necrosis with multiple foci of calcifications. There are even multiple retroperitoneal lymph nodes, and these features are suggestive of this large adrenocortical carcinoma. Again, we can see here on the right suprarenal lesion or the right adrenal lesion, which is pushing the kidney downwards, and the lesion is showing infiltration into the IVC. These are the axial T1, T2, and diffusion images. Here we can see there is a smooth iso2 hypointense lesion on T1, and the lesion is appearing very bright on T2. However, the lesion is showing significant diffusion restriction, and on contrast, dynamic contrast enhancement, the lesion is showing intense heterogeneous enhancement in arterial and venous phase with subtle areas of washout in the delayed phases. So this turned out to be an adrenocortical carcinoma, though even it was very smooth rounded. However, because of diffusion restriction. In metastasis can be irregular, inhomogeneous, bilateral generally. High attenuation, like more than 20 HU. Enhancement can be inconsistent, whether more it can be delayed, contrast washout can be seen. Iso intensity or slightly less intense than the liver in T1 and high to intermittent intensity on T2. These are the in-phased and out-phased or opposed phase images in a patient with a known case of lung cancer. Here we can see in in-phase, the lesion is appearing almost isodense, isointense to the adjacent spleen. Whereas in opposed phase images, we can see there is no signal dropout, or almost the lesion is maintaining the same signal intensity as that of the spleen in in-phase and out-phase images, and hence the mass was labeled as either an atypical adenoma and a metastasis, and further biopsy was done, and which turned out to be a metastatic deposit, as already the patient was known case of lung cancer. This again, here we can see there is a known case of again CA lung, where we can see there is a heterogeneously enhancing mass in the adrenal. Now, so the adrenal is one of the most commonest site of metastasis to adrenal is from lung. So any patient of CA lung, that's why we cover, or any lung pathologist, we cover the sections up to the upper pole of kidney or including the adrenals, so as to rule out any adrenal deposits in the case of CA lung, which generally tend to metastasize to adrenals. Though the most of the incidental lesions what we see in adrenals in a case of malignancy turned out to be most of the times will be benign only. However, the adrenal is a very common site of metastasis in the case of CA lung. That's why we include adrenals in the CT lung protocol. So next, coming to myelolipoma, this is a benign tumor containing a significant amount of fat. On ultrasound, they predominantly appear as a heterogeneously hyperechoic lesion in the suprarenal region. Can be heterogeneous depending upon the areas of bleed, if it or necrosis. and the enhancement is seen in the soft tissue component, and sometimes calcification can also be seen, and which can be punctate. On T1, they generally appear as hyperintense, and T1 fat set, there will be loss of signal intensity because of high amount of fat, and hemorrhage should be suspected if there is no significant fat suppression. And on contrast, post-contrast imaging in MR, the soft tissue will enhance. So these are multiple images of myelolipoma. Here we can see there will be a well-defined oval or round-shaped lesion, which will be heterogeneous, and predominant areas of hypodensity will be seen, which will correspond to the fat attenuation values. And here we can see this is a significantly hypoattenuating lesion. So this is classically suggestive of a myelolipoma with macroscopic fat. And here we can see a small foci of microscopic fat also as compared to these lesions. Here we can see there is an myeloid component is there, a fatty component is there, even calcification. So that's why the myelolipoma is it is labeled. And on the MR images, here we can see this is an T2 image where we can see there there is a hyperintense area within the lesion. And on T2 fat set, as we can see, the fat has suppressed here. Even the lesion is showing suppression. We suggest there is significant macroscopic fat, and this features again favor it is a myelolipoma. This is again another plain CT where we can see there is a large lesion with significant areas of macroscopic fat. This is a T1 weighted image where there are significant areas of T1 hyperintensity within the lesion, and those areas are showing suppression on fat set images. This suggests of a myelolipoma. Next, coming to the hyperfunctioning adrenal neoplasm, most commonly we see that is a medullary or cortical. Mostly we see is that pheochromocytoma, and the other ones are the cortical neoplasm, the Cushing's, Conn syndrome, and hyperandrogenism. So pheochromocytomas are the tumors originating from chromaffin cells of adrenal medulla, generally unilateral and benign. 10% rule is we all know that is, and the clinical features can be because of sympathetic hyperactivity. So there are many syndromes which are associated with pheochromocytoma, that neurofibromatosis, VHL, Men's syndrome, Sturge-Weber. So in pheochromocytomas, most of the lesions are solid, typically homogeneously solid, and they involve generally ranging from 1 to 20 centimeters and involve the adrenal gland, unilateral or bilateral. Sometimes extraadrenal pheochromocytomas are seen, which is 1% are seen in the organ of Zucker-Candle, which is located near the carotid bifurcation or adjacent to the origin of inferior mesenteric artery. And other well-described sites are the wall of the bladder and paravertebral area. In ultrasound, they can have a varied appearance depending upon hypoechoic or heteroechoic and areas of necrosis or hemorrhage. CT is considered as a modality of choice, and here we can see an oval or round-shaped masses, and because they are vascular lesions, and they enhance uniformly after the administration of contrast. So these are the series of multiple different patients of pheochromocytomas. Here we can see there is an intensely enhancing lesion in the left adrenal gland. Similarly, there is another intensely enhancing lesion in the right adrenal gland. And here again, we can see another enhancing lesion here. But there you can see there is areas of heterogeneous enhancement. So these can represent areas of necrosis, even can be seen within the pheochromocytoma. Not all pheochromocytomas tend to show homogeneously intense bright enhancement. They tend to show heterogeneous enhancement because of their size and areas of necrosis. Here also we can see there is areas of necrosis with heterogeneous enhancement. And here we can see this was a case of a patient presented with paroxysmal attacks of repeated headaches and hypertension. We can see there is an oval-shaped heterogeneous enhancing lesion with multiple well-defined cystic areas. These are actually non-enhancing and well-defined cystic. And these turned out to be pheochromocytomas. So pheochromocytomas tend to be not only homogeneously enhancing solid tumors, they can have cysts, hemorrhage, or necrosis. Can in any form they can present, and that's why pheochromocytoma is called as chameleon tumor of adrenal gland. Here we can see another large pheochromocytoma of adrenal, where we can see significant area of necrosis within the tumor because of its large size and hyperperfusion lesion. There is a significant area of necrosis is seen. So as any other tumor, we can see it on T1 they will be generally slightly lower than solid organs, and T2 they will be intermediate or bright signal, and no significant changes on the chemical shift imaging because of no significant lipid. This was a case of neurofibromatosis. Here patient was found to have instantly found some lesion on the CT, and then MR was asked. These are the in phase and opposed phase images. Here we can see there is a iso to hypointense lesion in the right adrenal gland. On the opposed phase images, the lesion is not showing any significant signal drop. So this was an indeterminate lesion. On post contrast, we can see there is significant intensely enhancing lesion and with a small area of necrosis. When this was correlated with the catecholamine levels, this turned out to be a pheochromocytoma. So again, this is another case of pheochromocytoma. Here we can see the lesion. This is the arterial phase and the venous phase. In arterial phase itself, the lesion is showing significant bright enhancement with persistent enhancement in venous phase. These are the supporting imaging features we can see here. This is an MIBG SPECT scan and FDG PET scan, where we can see the lesion is still hypermetabolic on both these scans. Here, so we can, because of the chromaffin cell secretion, chromaffin cell tumor, and secretion of the catecholamines. So they brightly enhancing lesion and appearing hypermetabolic on both nuclear medicine imaging, so suggestive of an pheochromocytoma. Then coming to adrenal cortical neoplasm, that is, these are a bit rarer lesions. Cushing syndrome, that is, this can be ACTH dependent or independent, and it can be seen in adrenal adenomas or carcinomas. In generally in imaging wise, we see only bilateral uniform adrenal enlargement can be there, or small nodule, sometimes very small nodule like a functioning adenoma can be there. So like that only the same hyperaldosteronism also, like adrenal small adenoma or adrenal hyperplasia or an adrenocortical carcinoma. Generally these tend to be very smaller lesions. And here we can see a patient who was having a suspected case of hyperaldosteronism. We can see a small, very small tumor in the left adrenal gland. So since it is a functioning adrenal tumor, so this has to be excised, and then the patient would revert back to normal blood levels. Then here it was a case of Conn syndrome, and here we can see there is a small right-sided adrenal nodule, which is very small. However, the nuclear medicine scintigraphy scan showed a significant uptake corresponding to a functional small adenoma. Hence, this had to be excised. Sometimes the adrenals undergo hypofunction also in cases of like autoimmune disorders, infections, sudden adrenal hemorrhages, or due to drugs. So infections are most commonly, we generally tend to see bilateral and can be seen commonly by tubercular and histoplasmosis in our setup. So here we can see there is a multiple punctate-like calcifications involving both the adrenal glands, and this setup is generally seen, this kind of imaging is generally seen in post-COX or histoplasmosis in our setting. And adrenal hemorrhage, this can be traumatic, and most commonly it will be, and non-traumatic, and bilateral 20% of cases. It is important to recognize adrenal hemorrhage because the patient can land up with adrenal insufficiency. So here we can see there is a well-defined oval-shaped hyperdense lesion involving almost entire gland, and this patient had trauma. Here the additional findings we can see there is a right perihepatic fluid and antiperinephric hyperdense fluid suggestive of maybe hemo component, and this is a right adrenal hemorrhage. Corresponding left adrenal, we can see the beautifully normal orientation of Y or V shape with no focal lesion. This is another axial non-contrast CT. Here we can see there is two well-defined oval-shaped lesions which are relatively hyperdense to the adjacent solid organs, suggestive of acute non-traumatic bilateral adrenal hemorrhage. So this patient landed up with adrenocortical insufficiency. So just to summarize, the normal benign adrenal looking lesions we commonly tend to see in the CT on plain scan this is an adrenal adenoma, which we, as I already told, if it is less than 10 HU, mostly we will label as adenoma in our routine practice. And if we see a fluid attenuation within it, sometimes we can label it as adrenal cyst. And sometimes these cysts can show foci of calcification. And if the lesion is generally homogeneously macroscopic lipid, then it will myelolipoma. Myelolipoma can sometimes also show small foci of punctate calcifications with a heterogeneously enhancing myeloid component also. And sometimes benign endothelial cyst or a parasitic cyst can also be seen in in the adrenal gland with a foci of calcification. So this is just a chart like mass more than 1 centimeter. Benign includes adenoma, myelolipoma, cysts, and calcifications. Indeterminate 1 to 4 centimeters, more than 10 HU, washout, lipid poor adenoma. We have to do an MR imaging. If it is lipid, then if it confirms the signal drop, then it is lipid poor adenoma. If it more centimeter than 4 centimeter, probably adenoma follow up for 6 to 12 months. And there is no washout, then we will think of pheochromocytoma, carcinomas, metastasis, and everything. And the imaging is indeterminate and it is more than 4 centimeters. No history of primary malignancy, then consider resection. And if it is a history of malignancy is there, biopsy or PET CT. So in conclusion, most of the adrenal masses are incidentalomas, and among them, the adenomas are most common and mostly which can be it can be functioning or non-functioning, and most of the adrenal adenomas are also non-functioning. Some adrenal adenomas may have pathogenic CT features such as myelolipoma, cysts, and malignant masses. However, most of the adrenal tumors again have non-specific features. Most adrenal adenomas are lipid-rich and can be correctly diagnosed on chemical shift imaging along with unenhanced CT. Most lipid-poor adenomas can be accurately diagnosed using delayed CT or chemical shift imaging. And percutaneous biopsy can be limited to larger masses whose imaging studies are not specific and do not indicate an adenoma. Thank you.
Thank you, Dr. Arun sir. That was quite a exhaustive lecture covering all the imaging features on CT and MR of all the adrenal lesions, mainly differentiating between adenomas and other lesions. I now ask Dr. Rajendra sir to share his clinical inputs on adrenal lesions.
So one thing, sir, like it is these are like some things like as you said. I mean, Dr. Arun, that was actually a very comprehensive coverage of the wide range of the adrenal pathologies. Nicely done. It's nicely done. It's an exhaustive topic. Well, and one that we don't actually see very commonly in clinical practice, like because they're not very common, but it's a good presentation of highlighting the important aspects. I think from what your presentation and my experience, the thing to see is like there are the way it categorizes either they're benign, functioning, benign, non-functioning, or malignant. These are the three mainly that we see clinically. Like you said, it would be like if it is less, if it got less Hounsfield units and size is less and there is no evidence of any function, then it is very clear. We don't need to follow up. We don't need to, no follow-up imaging, no treatment. If it is more than 18 Hounsfield units, like you say, and the size criteria, then the question comes as to the safer thing to do would be to consider it as a possible malignancy if it is not functioning. If it is functioning, then manage him for a couple of weeks, like depending on the pathology, the functional status of the tumor, and then prepare him for surgery and proceed with it. If it is non-functioning but there is signs of malignancy, again it comes to actually surgical treatment, i.e. adrenalectomy.
Dr. Rajendra, I have a question for you. Like, what is the role of biopsy in adrenal lesions? In like, we come across a lot of indeterminate lesions. Like, how do we go about it?
Like I will be honest, sir. Like we don't see many the adrenal tumors on a regular basis for us to have a large number, particularly for us general urologists who actually are not into cancer practice. Most of the patients, once they have a tumor, they go to that. So, but whereas like the question comes, the when it is not obviously functional and not obviously malignant, but not convincing enough to be benign, then it is a question of actually biopsying it to be sure that what we are dealing with is a malignancy. Because if it is functional, then then there is no ambiguity in the treatment. We just go ahead with the surgery. If it is non-functional and then there is the size criteria is suspicious, size criteria or the Hounsfield criteria is suspicious but not suspicious enough to be obviously malignant, when it is that gray area, then I think that would be, there would be a role for biopsy in that situation.
Okay. So, sir, like, is there any role of surgery in a known cancer patient with a single adrenal lesion and no metastasis in other organs?
So a known cancer lesion.
Yes, known cancer with a single adrenal lesion and no
Mm-hmm.
metastasis in liver or lungs. So,
Yeah,
is that?
definitely. That would be the indication for adrenalectomy.
Yeah.
I mean, just to clarify, you're talking about the cancer in the
Cancer.
adrenal
Yes,
gland.
right.
Yeah,
Yes.
yeah, no, yeah, definitely. That would be an indication for adrenalectomy.
Yes, sir. Dr. Arun, sir, you have any questions?
No.
Thank you, sir. I thank Dr. Rajendra sir for giving his time and is also clinical input regarding imaging in adrenal lesions. I also thank Dr. Arun Santosh for presenting us such a wonderful topic on adrenal lesions. Thank you.
Thank you very much, Dr. Rajendra sir.
Thank you, sir. Thank you, both of you, and thank you for the opportunity. Okay.
Thank you.
Thank you.